Let us review the anatomy of the esophagus that is relevant to endoscopy technicians, nurses, and trainees. So here is a woman who came in with acid reflux and heartburn, and we are performing an endoscopy. The endoscope is in the esophagus at the lower end, looking at the lining. So as we do this case, let us learn about the anatomy that is relevant to the esophagus. Before we go there, let me take you through briefly the different parts of the gastrointestinal tract, starting from the oral cavity to the anal canal. So, oral cavity, pharynx, esophagus, stomach, small intestine, colon, rectum, anal canal. And let me label them here. Oral cavity, pharynx, esophagus, stomach, small intestine, colon, rectum, anal canal. Let me take you through some definitions. Proximal versus distal. If you take the star as a starting point, the one that is closest to the star is proximal, and the one that is away from the star is distal. So as you can see here, the stomach is distal to the esophagus, and the esophagus is proximal to the stomach. So you got the message here. And some more definitions. Anterior, that is front. Posterior, that is back. Superior, that is the top. And inferior, that's the bottom. And as you can see here, the esophagus goes through the neck, chest, and abdomen. The portion of the esophagus in the neck is called cervical esophagus, in the chest, thoracic esophagus, in the abdomen, abdominal esophagus. First rib separates the neck and the chest, and the diaphragm separates the chest from the abdomen. And let us learn a few more points relevant to the esophagus. What are the structures in front of the esophagus? That is, structures anterior to the esophagus and structures posterior to the esophagus. Let's start with structures that are anterior to the esophagus. As we go from the neck down through the chest and abdomen, the first one is trachea, then left bronchus, and heart. These are the structures or important structures that are in front of the esophagus or anterior to the esophagus. Then let's talk about structures that are posterior to the esophagus. For the most part, it is the spine and then the aorta. So, let us talk about the endoscopic anatomy that was relevant to us. And as you can see here, the scope is all the way close to the lower end of the esophagus, between just above the junction between the esophagus and stomach, or close to the lower esophageal sphincter. There are two sphincters in the esophagus, one at the upper end, the upper esophageal sphincter, and the one at the lower end, the lower esophageal sphincter. So as you can see the lumen of the esophagus on the endoscopy monitor. And if you want to find out where it is, let me show you in this diagram. So the endoscope has gone all the way to the junction between the esophagus and stomach. And to learn a little more, let us go back to the structure of the body. And as the scope goes from the enters the buccal cavity and goes down the pharynx and esophagus into the stomach, it goes through several areas that are relevant. It takes about 15 centimeters length of the endoscope from the lips to the upper esophageal sphincter, and about 40 centimeters length to the lower esophageal sphincter. That's about probably true in most adult males of average height in the United States. It may change depending upon where you practice, depending upon the body habitus, maybe a little less or a little more. So once the scope is down the oral cavity and into the pharynx, and as it goes into the hypopharynx, you see the larynx. And in the larynx, there are several important structures to identify. The fold that covers the larynx is the epiglottis, and then the voice makers are the vocal cords, and below that, two cartilages, the arytenoids, and to the side, a recess called piriform fossa. So when you do the endoscopy and you want to enter into the esophagus, you come down the pharynx and enter the piriform fossa, either on the right side or left side, and then turn towards the middle and gently push. That's where you encounter the upper esophageal sphincter, and once you go past that, you reach the esophagus. Upper 1/3, middle 1/3, lower 1/3. As you can see, the lining is light pink in color, and as you go down, you reach the lower esophageal sphincter, and that's where you notice a change in the light pink squamous mucosa to beefy red columnar mucosa of the stomach. So let me point it out. That is the squamous mucosa, light pink in color, and columnar mucosa of the stomach, that is beefy red in color. And when you look under the microscope, the squamous mucosa has a lot of flat cells in multiple layers, and columnar mucosa is a single layer of columns or cylindrical cells. So I hope you understand the difference between the squamous mucosa and the columnar mucosa. Let's look at the measurements. So as the endoscopist is doing the procedure in the esophagus, when he reaches the lower end of the esophagus, he will call out certain measurements to define the anatomy of the lower esophageal sphincter and its relationship to the diaphragm and what is happening to the junction between the squamous lining and the columnar lining of the esophagus. So he may call out and say Z line, like the zigzag line, or the junction between the squamous and columnar mucosa, or squamo-columnar junction, or SCJ. So that is the junction, as you can see here. Usually in an adult male in the United States, it is about 40 centimeters. And then he may call the top of the gastric folds or the gastroesophageal junction, usually measured by the top of the gastric folds, and that is the gastroesophageal junction. In addition, some people will take the trouble of talking about the diaphragmatic hiatus pinch, or the hiatus. And the hiatus is where the diaphragmatic muscle pinches on the esophagus when somebody takes a deep breath during the procedure, or when somebody is breathing in and out, you can see the diaphragmatic pinch. All right, so 3 measurements: squamocolumnar junction, gastroesophageal junction, and the diaphragmatic hiatus. So these measurements will help us figure out whether somebody has a normal lower esophageal anatomy, or whether they have Barrett's esophagus, or whether they have a hiatal hernia. So we will talk about it in the esophageal pathology, a little more about these measurements. So as we see, we have come down the lumen of the esophagus, and as you can see this on the cross section, what the lumen looks like, and the wall of the esophagus. And it's also important to learn about the wall of the esophagus and take time and figure out how many layers are there in the wall of the esophagus. It's probably true whether it is in the esophagus, stomach, or small intestine or colon. There are 4 layers. These layers include the mucosa, submucosa, muscularis propria, and adventitia. In the stomach, small intestine, and colon and rectum, you have serosa covering the muscularis propria instead of the adventitia. And why is this important? Why is that you need to know about the layers of the gastrointestinal tract or the esophagus? It's important because when you do, you have the ability to look at these layers with endoscopic ultrasonography. When you do this exam, you can see the layers of the esophagus, and knowing what is happening in the layers, you can figure out the stage of the cancer or the location of the tumors in the esophagus. So let us talk about a little more about these different layers. The inner layer is the mucosa, and the mucosa of the esophagus, for the majority of it, it is squamous mucosa. A little bit towards the end, it's columnar mucosa. And we looked at the difference in the structure under the microscope. The squamous mucosa has squamous cells, columnar mucosa has columnar cells. Then let's talk about submucosa. Submucosa has a lot of connective tissue, a loose tissue that contains blood vessels, lymphatics, and nerves and glands. And then outside the submucosa, you have muscularis propria, and it contains an inner circular muscle and an outer longitudinal muscle. And these muscles are important to move the esophagus or to push food down. And outside the muscle, you have adventitia. It is a connective tissue that connects the esophagus to various organs inside the chest. So let us take a moment to look at the blood supply of the esophagus. This is very important to keep in mind. As you can see, majority of the blood supply comes from the aorta through the esophageal branches. The lower portion of the esophagus, the intra-abdominal portion, gets its blood supply from the celiac artery, left gastric artery, esophageal branches. The upper portion of the esophagus, the one in the neck, gets its blood supply from subclavian artery, inferior thyroid artery, and esophageal branches. So let's talk about venous drainage. As you can see here, you have the heart, and that drains the upper limbs, neck, and head through superior vena cava, and the lower limbs and kidneys and the genitourinary area through inferior vena cava. And then the esophagus drains from esophageal veins, and they can either go into the superior vena cava or into the inferior vena cava. So the esophageal veins, the lower portion of the esophagus, drains into the portal vein, and the portal vein comes into the liver, and the liver drains into the inferior vena cava and enters the heart. The upper portion of the esophagus drains through the esophagus vein and into the superior vena cava. As you can see here, The esophageal veins could be a bypass route if there is a blockage to either the superior vena cava or the inferior vena cava, along with the esophagus vein. So, in summary, we've learned a lot about the esophagus anatomy, and I hope this is useful. And we will discuss a little more in depth when we talk about the pathology of the esophagus, when you'll appreciate the underlying anatomy. Thank you.